it is. Thank you very much, John. And now it is my pleasure to introduce you to the last speaker. It is Jorge Alio de Barrio, and he will have a very nice presentation as well, where we will go face the darkness during cataract surgery. And I'm looking forward to your presentation, Jorge.
Good afternoon. First of all, I would like to thanks to Maria José Tasignon and Roberto Beruzzi, the moderators of this great webinar, for the nice invitation and for the possibility of sharing with you this complex case that I recently had. So this is a North African 36 years old lady presenting to our clinic with irreversible corneal edema, glaucoma, controlled with topical medication, cataract, and an ischemic mydriatic reflective pupil due to a cosmetic iris prosthesis that was explanted overseas 6 months before, and now she came to our clinic to see if we could do anything for her vision that, as you could expect, was very poor, of only counting fingers. You see, this is the preparative slit lamp and the topography, the preoperative topography. We see that the patient is presenting a severe corneal edema with a severe reduction of the corneal transparency and the reflective pupil cataract, and of course an angle closure glaucoma. So the problem is here, how should we face the visual rehabilitation of this patient? Because we have several options. Because one of the main problems is the poor visibility. So we have a very poor visibility, the corneal edema is quite severe. So in order to do properly the phaco and safely, we could do first the DMEC followed by the phaco. But here the problems would be not only the poor visibility to do the DMEC, but also the shallow anterior chamber, because we shall remember that here, as we usually get in these patients, we have an angle closure glaucoma, and then we don't have proper space in order to work safely for a DMEC, and also we have the fixed mydriatic pupil. Other option would be to do first the phaco followed by the DMEC, in order to release the space, open the eye, and then have enough space to later do the DMEC. But the problem here is that if we do the phaco first and the visibility is poor, the visibility is going to get worse because the corneal edema would get worse, and that will preclude later the options of doing a DMEC, because if we can't see, we cannot do the DMEC. So by doing the phaco here first, I didn't feel it was a good idea, because then later could make me impossible to do the DMEC. So then what I did is the third option, that is to do a combined phaco DMEC, because although we still have the problem of having a poor visibility during the DMEC, by doing a combined procedure, we are opening the eye. By removing the crystalline lens, we are solving the shallow anterior chamber, and also if we do a pupilloplasty, also we are solving the problem of the fixed pupil. So this is the surgery. Okay, so as you probably know, in order to do these cases, to do a phaco in a patient with corneal edema, it's very important to remove the epithelium, because only just by removing the epithelium, the corneal transparency increased significantly. So this is very important when we face the cataract in such patients, okay, to remove always the corneal epithelium in order to clear the transparency as much as possible. So here I do a 3-step main incision with two paracentesis. Okay, here, although I have a mydriatic pupil, I injected some mydriatic in order to make sure I have a proper dilation. Okay, and of course here, in order to try to enhance the visualization during the capsulorhexis, I put some vision blue. Okay, in a normal case with a normal, I mean in a difficult cataract case with normal cornea, I usually don't put air with the vision blue, because really if the endothelium is normal, you don't get the stain of the endothelium, and then it's not a problem. But of course, if I have a corneal disease, an endothelium disease, you should always put air, okay, over the vision blue, because if you have some stain of any corneal endothelium disorder, then the visibility is going to be even worse. So here, after staining the capsule with the vision blue, I'm trying to do a capsulorhexis, but then at this point, I realized that I cannot see anything, and I cannot move forward safely. So then at this point, it reminded me Frodo from the Lord of the Rings at the Return of the King, when he was alone in the cave. He couldn't see, he was afraid, and he couldn't move forward. And then he used the Arendi light in order to could solve the situation. That is a light given by the elves to use in dark places when all other lights go out. And to be honest, at these stages, I felt like Frodo. And then what I did is use the R&D light that I had, that is the light of the vitrector. So all of us in any ophthalmic theater, we can have, and we have from the VR surgeons, the lights, the endolights that they use during the pars plana vitrectomy. And then these lights are extremely useful when you're facing a cataract, okay, where you cannot see, okay, because once you put this light inside the eye, that will increase the illumination from inside the eye, okay, and that will enhance a lot the visibility of the intraocular structures, okay. And as you can see here, by implanting through a new paracentesis this endolight, then I can move forward with the capsulorhexis that it was already stained with vision blue, okay. Here, we shall remember that this is a phacodymic, okay, so here we should target a no larger than 4 or 5 millimeters capsulorhexis, because then later we're going to do the dymic with tapering technique, and if we have a large rhexis, this is going to increase the risk of having a anterior luxation of the intraocular lens, okay. So as it is a phacodymic, moderate or even a slightly small capsulorhexis, okay, here I have hydrated the nucleus. And then, as you already know, these white cataracts in young patients are usually soft, okay? So I tried to phacoaspirate the whole cataract, okay? But I was struggling slightly because some hardness. So as you're gonna see now, okay, I needed to do some crack, okay? So the problem is that I have only 2 hands, so I asked the assistant to keep the endolight in place. It's always difficult as an assistant to keep it in place. But now here with a chopper, I'm doing some cracking of the crease of the cataract, okay, in order to be able to continue. And now once it's cracked, I'm gonna recover myself the control of the endolight, okay, that although it's not gonna be able to do any chopper, it's a side instrument that is gonna help me to move the fragments of the crystalline lens, okay. So yeah, I will not, it's not useful to crack, it's useful to move as a side instrument to move the fragments. So here, as you can see, I could continue, okay, aspirating the fragments of the white cataract. Okay, and here again, I am asking the assistant to help me with the irrigation aspiration, to help me with the light in order to do bimanual irrigation aspiration to remove all the cortex and clean the capsular bag. Okay, so once the capsular bag is clean and the I&A aspiration is completed, okay, then I'm going to implant and insert here a 3-piece monofocal lens, of course, a regular monofocal 3-piece lens, okay, with previous some viscoelastic injection. Okay, so here, as you can see, this R&D light from Frodo, our R&D light is just the endolight from the vitrector, helped me and assisted me in order to be able to complete successfully a cataract that at some point I was stuck because I couldn't see and I felt that I couldn't continue safely. Okay, so once the cataract is finished, then I moved forward with the dymic. Okay, my dymic regular technique, I always dissect the grafts myself, okay, because I know to do it, I like to do it, okay, and this is my harvesting technique of the endothelium for a dymic. Okay, first I peel 50% of the endothelium, then I do a partial trephination. Okay, this is, I think it was a 8 millimeters dymic. Then I remove the peripheral endothelium to make sure I don't have any tags. And then I always use as a assistant mark an asymmetric triangle, okay, in order to assist later the position and the orientation of the dymic graft once it is inside the eye. And only with a one-touch technique, only one touch, then I complete the dissection of the dymic graft. Okay, so here you see it's only one touch. I'm peeling the whole endothelium, okay, and it's ready for insertion. So once the dymic is ready, then I use the same trifine, not to trifine the recipient cornea, but only to mark with ink the diameter that is going to occupy the dymic, okay, in order to know and assist how large should be the descematolrhexis from the recipient cornea. So as this is a phacodymic, now I have the eye filled with viscoelastic. So as it is easy, I like to do the peripheral 360 degree mark, okay, to later be able to peel endothelium easily. But I know many surgeons do a full descematolrhexis under viscoelastic. I personally don't like. I like to use it under air, to do it under air. I think is the best technique in order to minimize any risk of rebubbling. So after this 360 marking and demarcation of endothelium, I remove the whole viscoelastic, and then under air, I will complete my descematolrhexis. Okay, This patient, as you remember, is not a Fuchs, it's a pseudophakic bullous keratopathy of a patient with a prosthetic iris implant. Okay, and these cases usually I find a lot of difficulties. Sometimes you find difficulties in order to do desmotorexis because there is a lot of fibrosis in the descemet membrane, and sometimes, quite frequently, is the desmotorexis in such cases are difficult. And here I was having quite a lot of difficulties in order to do desmotorexis, okay, because of a strong adherences of the descemet membrane to the overlying stroma. So here, as you can see, I obtained a slightly smaller than expected desmotorexis, but as I was covering very well all the visual axis, and I didn't want to mess around with the stroma, creating the stroma attacks that later could preclude the correct adherence of the DMEC, I decided to leave it as it was and give it by good, okay, and proceed with the DMEC. So here I am pre-placing the stitch of the main incision, and now I'm gonna insert the DMEC graft, okay? I always, once in the guided injector, that is the one I use, I check the orientation. Where is my double scroll, okay, in order to know once the injector is in, how I need to swab it in order to make sure that I inject the graft in the correct orientation, okay, with endothelium facing down, okay? So with my irrigation, I inject the goiter, I put inside the goiter injector, okay, and once I feel I'm in the proper position, I remove the INA to collapse the eye, and then I inject my DMEC. This, I felt that they had a lot of positive pressure. Remember, this angle closure glaucoma had a lot of difficulties along this DMEC eye. Okay, so you saw that I struggle a bit in the injection. So to make sure I don't miss the graft, I close the stitch. Okay, I'm starting with my tapping technique in order to unroll the graft. Okay, this case, due to the poor visibility and also due to the shallow anterior chamber, even improved after the lens removal, it was quite a difficult DMEC, I have to recognize, and you will see that I had to do a lot of tapping technique and also assisting with air. I was putting air, removing it and putting more, okay, in order to help me to unroll the graft, okay, you see, putting it out in order to help me to unroll the graft, because it was quite difficult because of some positive pressure, peripheral iris adherences, and poor visibility, okay? But in the end, I got it, okay? I had a proper orientation assisted by the mark. Here in the video is not very well seen because, you know, poor visibility and the video always some quality is lost. Okay, here I'm trying to finish the unfolding of a superior fold on the graft, and now here with a 30 gauge needle, I injected some more SF6 through the parasites, through the limbus, okay, in order to enhance the amount of gas in order to keep the DMEC graft in place, okay? So here, because of the positive pressure, I couldn't get a bubble larger than the one you see here. So, but it was okay, pressure was high anyway. I closed all the paracentesis because the cornea was a bit poor, okay, and sorry for this text, okay, and here I'm concluding the case, okay, with some subconjunctival antibiotic. So this is the one-day outcome. You see that the corneal transparency is almost fully recovered, okay, the eye was a bit inflamed as expected. Gas was about 50%, that was enough in order to keep the graft in place. And as you see in the anterior segment OCT image, the DMEC graft is totally attached, and actually the corneal thickness is already improved near to normal limits. 1 week after the procedure, the cornea was clear. As you can see here, the DMEC graft was in the correct orientation. Here you see the proper folding upwards of the DMEC graft, confirming the correct orientation. And I cannot show you the long-term outcomes because this patient was from overseas, and after this visit 1 week, the patient left, and I have not been able to see her again because she has not come back for follow-up. I hope he's doing well and having proper checks at her country, okay? But hopefully, I think she's about to come next month. So as a discussion of this case, okay, basically the message I wanted to give you is that a regular pars plana vitrectomy endolight that is available in any ophthalmic theater, okay, is extremely useful for cataract surgeries where visibility is poor due to moderate corneal opacity, either because of scars or because of corneal edemas, where the trypan blue is not enough. Of course, in this case, it's always trypan blue assisted with air to avoid any staining of the diseased corneal endothelium, because if not, you can make the situation even worse. So if you have a normal corneal endothelium, normal cornea, you can do vision blue without air. But if you have a corneal disease with a corneal endothelium disease, you should always put air, because if you stain with vision blue the endothelium, then you are done and you cannot continue. Okay, so always assisted with air. But if even though you cannot see, as in this case, okay, then remember Frodo, okay? And remember the R&D light that Frodo used in the Return of the King in order to solve the situation where he was lost and alone in the darkness, okay? So this light can solve the situation in such difficult cases. Of course, if the opacity is complete, okay, and you cannot see anything from preparative assessment, you should do first the corneal graft or even an open sky cataract surgery if it is a PK, okay? But if the visibility is in the limit, is moderate, you can try with vision blue, and if it is not enough, you can use your endolight, okay? Retrospectively, looking at this case, I regret about not doing the pupilloplasty just before the DMEC, because I think, to be honest, I became lazy. I was a bit stressed about the case. I didn't do the pupilloplasty. Everything in the end was fine and it worked. Although it's true that I regretted, because during the DMEC surgery, because of not having the pupil constricted, I was problems with the IOL luxating anteriorly, and also at some point the DMEC graft also went behind the iris and I had to rescue it. So probably if I could move back, okay, I would have probably make some extra patients in order to be in between the cataract surgery and the DMEC to do the pupilloplasty in order to close the pupil, and that probably for sure could have made the DMEC easier. In the end, it worked, it was fine, but probably it's something that I could have improved in this case about doing a pupilloplasty in between. Thank you very much for your assistance.
Thank you, Jorge. I think we are all astonished by the complexity of this case that was really difficult. You feel you could have done a pupilloplasty. However, this also should have included peripheral iridectomy, inferior peripheral iridectomy, to face the huge amount of air that's required in the anterior chamber. But going back to the idea you had of using a vitrector illuminator for cataract surgery, keeping it inside the eye, I never saw this, and I think this is the idea you had just to solve this case. Do you think that the previous use of the trypan blue could have worsened actually the visibility inside the eye, although staining the anterior capsule? Should you go back, would you use again at that stage trypan blue, or simply would you use the vitrector illuminator to try and perform your capsular axis without any staining?
Well, I would, the only thing I regret about this case is about not doing the pupilloplasty, because in the end, this is not shown in the video because it is long, but there was a point where the DMEC went behind the iris and I was sweating, and I probably became lazy. I didn't do it, and I probably regret it. But and I could, even if I do a pupilloplasty, I can do later an inferior PI just before injecting there. Nevertheless, regarding your question, yes, I would, because the point is what I said, that here the point is to protect the endothelium with air once you inject the vision blue, because if you don't do it, then all endothelium will stain and then you are done. You cannot see anything, and that's a big problem. But as far as you protect endothelium with air and you do a careful injection, the cornea won't stain, and actually in this case it didn't, and I believe that without the vision blue it would have been almost impossible. I think the vision blue is a must in these cases, even with the endolight.
Thank you. And you already discussed the alternatives. I would like to ask a question about the visco you used and the way you suggest to remove visco before doing the DMEC.
Yes, well, this is a personal preference because, as I said, many surgeons, good surgeons that do DMEC, they do the desmotorexis under viscoelastic. To be honest, I train by not doing it that way, I keep it because first, visibility of the desmonatorexis is much better under air than under visco. And I'm always afraid about having any residual viscoelastic during the desmonatorexis that later could preclude the good adherence of the DMEC. And actually, when I have compared, even when I was a fellow training in DMEC, in Moorfields, and I was comparing my rebubbling rates, being a trainee, with my consultants' rebubbling rates doing viscoelastic, mine were lower. Well, this is just a personal opinion, but on my hands and on my experience, I really believe that by doing under air, there is less chances of having any residual viscoelastic and so less rebubbling rate. But as I said, all techniques are valid. It's just a question of personal preference.
Thank you.